Hi everyone, and welcome to the final session of HTN Now Digital Primary Care. We hope you've enjoyed the day so far. If you've missed anything, head to htn.co.uk in the next couple of days and you'll see our write-ups and all recordings from each session. For our final webinar, we focus on going beyond BP at home and making technology do the work. And we welcome Dr. Jonathan Sargent, the CMO from Generated Health, and Dr. Matthew Davis from NHS Bedfordshire, Luton and Milton Keynes. So just before I hand it over to the team, if you have any questions during the session, please type them into the chat. We've got a planned Q&A for the end of the session, so type them in as we go and we'll see them as they come in. This session is also being recorded, so you can watch it back at a later date, and that'll be available on htn.co.uk shortly. So to kick off, Jonathan, could you tell us about yourself and a bit about Generated Health, please?
Yeah, sure. Thanks very much, John, and welcome. And thank you for everyone taking the time to come and joining in with this webinar. I'm Dr. Jonathan Sargent from Generated Health, and we run the Florence platform. The Florence platform is a communication platform that's intelligent and communicates with patients via simple SMS messaging in between your clinical consultations, and it has a great impact in supporting people to care for themselves and provide the relevant monitoring that you need to do, but also it reduces your workload, which are the two key things that we need to try and achieve. So I've unfortunately, Matt Davies hasn't been able to find time for today, so I did an interview with him yesterday, and we're going to play that, so please do put the questions in, as John has said, and then we'll have a Q&A at the end. So I hope you find it interesting and it sparks some curiosity and inspiration. Thanks. Joining us today at this HTN webinar. Just for other people, I'm Dr. Jonathan Sargent. I'm the Chief Medical Officer of Generated Health, and we run the Florence platform, which is an intelligent messaging platform. And today we've got the pleasure of Matthew Davies, who was one of our customers and in Bedfordshire, Luton and Milton Keynes. So Matthew, do you want to just introduce yourself and tell us a little bit of why you've landed working in what you do, and what you love about this, the work that you currently do.
No, that's right. Yeah, thank you for inviting me as well to come and speak today. Yeah, so just as I mentioned, so I'm Matt Davis. I'm a pharmacist with the medicines optimization team in BLMK ICB. So we work within the BLMK ICS footprint. So we're a large integrated care system, about 1 million patients. So what about my background? So how did I get here? So again, my background is within hospital originally. So I worked 13 years out of an acute local trust, and I spent the last 6 years working as the cardiovascular and the stroke lead within the trust. And I think while I could, while in those roles, while you could, influence things around you, we would see, you saw the effects of things like stroke and patients coming in with MI. And I recognise actually that there was a lot that could be done around primary prevention for those conditions. So again, obviously atrial fibrillation management and hypertension. So probably about 5 years ago, a job came up within Bedfordshire Clinical Commissioning Group, which again was a place-based lead. So it was looking after an area of GP practices. So again, it looked like a good opportunity to kind of take some of that learning out of hospital and also see how we could increase primary prevention and prevent other conditions. And then so and since I've been there, as we moved to the ICB, I've really pushed and managed to work as within the CVD long-term condition team, and really again we're there just trying to drive at mainly prevention of cardiovascular disease. We spent a number of years working on atrial fibrillation, so we feel in a good place at the moment. And again, we've got other areas to tackle, which we're currently looking at now within the ICB.
Right, that's fantastic. And you're a pharmacist by background?
Oh yeah, I didn't mention that. Did I? So sorry. Yeah,
that's good.
Yeah. So
that's
I'm
good.
a clinical pharmacist. So yeah.
Yeah, clinical pharmacist. That's great. And so what I also noticed about Bedfordshire, Luton and Milton Keynes ICB is that your sort of extra support working alongside GP practices to really address hypertension management. Can you just give us a little bit of a context for others so they can understand the relationship and how you're working and liaising with practices and their teams and their different clinical workforce?
So again, as we practice, as part of our practice facing team, again, we're able to, we do spend some time directly within practices, so we can gain that experience of, the management of the long-term conditions and the potential problems arise. So again, so we do work directly with them. However, again, we're also able to work at a more strategic level and identify potential issues around things like hypertension management, so that we can address those, on a large scale and try and implement strategies across the whole of the ICB.
Okay, that's fantastic. And because there are lots of places where I think practices are either working within their primary care network and just trying to solve this problem on their own and implementing technology on their own. And one of the things that has really been a pleasure to in working with working with you is that you're also really able to focus on some of the real barriers to technology implementation and help some of those those really busy teams not having to deal with that extra sort of time constraint. So in terms of the number of practices that you currently work with, how many are you currently working with?
So myself, we only work with a small number of practices directly. However, we cover, obviously, we've got a footprint, I think, of now 94 practices across the BLMK region. So very big variation in terms of things like hypertension management. Again,
tell us about that a bit.
So again, as I think with all ICBs, we've seen a drop off in terms of hypertension management since the COVID pandemic. We have a population of around 140,000 patients with hypertension. We've got a big gap between those managed to target compared to our ambition and the NHS ambition as well. And I think significantly, we also see a very big variation in management between practices. So again, we see there is a very big variation when we look at the data and we look at QoF. So we've got a number of problems that we need to look at and we're trying to address at the moment.
What do you think your sort of top challenges are in getting in hypertension management? Because it's a really big cohort, isn't it?
Yeah, I think we have to admit that the pure quantity and the numbers of patients is a huge impact. I think again, as we know, there can be an inertia around hypertension management as well. So again, we've been trying to address that. So sorry.
Right.
So again, the pure numbers, getting patients, obviously, that we don't have a huge number of GPs and healthcare professionals, so it's very difficult to make lots and lots of contacts with patients. It's very difficult to keep bringing people back into practice. Those are some of the problems that we've been trying to look at the moment.
So I mean, certainly, some of the current pressure in general practice across the country is very high, isn't it? And particularly around workforce, as you indicate. One of the real problems around managing a whole population of hypertensive patients is the sheer volume of workload that can happen. Now, of course, we know that practices have their QoF processes in place for regular review, but I suppose one of the differences that we're working on with this technology is having more communication with the patient in between consultations and helping patients helping patients manage themselves and provide information and provide blood pressure back to the practice. So I mean, you in particular as an organisation went out to start look for technology that supports. What were the sort of things that you were kind of looking for, and what sort of drove you towards Florence?
So I think what we kind of had, we had three key areas that we wanted to improve within our hypertension pathways. So again, obviously, as we kind of just mentioned, we wanted to improve the efficiency of the process for annual BP checks. And reduce the workload of practices. So again, that we can actually focus more on those patients that actually need interventions. So we again, as I mentioned, we got about 140,000 patients with hypertension. That's a huge pressure on our workforce in terms of workload. Again, we've got different systems that vary. Again, as some practices I'll be working in, we'll just be picking up patients as we go through, as a clinician, engaging with them, asking them for the BP. Some again will have processes such as letters. Again, if you're sending 200, 300 letters a month out to patients, that's a huge impact on your workforce. You've got to get all those blood pressures back, get them back into the system. Do they all come back? So I think improving the efficiency was one. The other area we've been trying to work on for a while is trying to empower patients to manage their hypertension themselves, to give them more ownership for their hypertension. So my thing is actually, why do we have to have an annual, the whole thing of the annual BP review, actually, why shouldn't we be encouraging people to check their blood pressure, quarterly through the year or every couple of months? Again, if somebody's hypertensive and you only pick it up once a year, they could be hypertensive in 6 or 9 months, so that the damage is done. And also motivating them that actually, if they are managing themselves correctly, how are they, giving them that, the positive, message that they're actually doing the right things, and are they taking their medications? And then I think the third thing, again, what we're looking to go out to technology about, was actually managing patients newly diagnosed. So we've been really working on a new streamlined process and guidance locally, to really minimise the number of contacts, and get patients again sort of self-managing themselves during that early part of the hypertension management protocol. And then again, a little bit of follow-up as they go, after if we can get them to management, then can we just follow them up for a few more months just to keep an eye on them and make sure everything is working as it was, if that makes sense. So a bit of the background how we went to Florence. We as part of the BP at Home work, we work closely with the local academic health science network, and they'd actually had a look at some of the available technology, and sort of done a little bit of evaluation around the pros and the cons. And actually, when we looked at it, the Florence system actually seemed to best meet what we needed, and therefore that's why obviously we went down that route in terms of looking at Florence as our technology of choice to answer these questions for us.
Yeah, well, that's fantastic. I mean, in your key areas, ensuring anything that we do, we've got to reduce workload in general practice. So we work really hard in the design of our protocols to try and ensure that that benefit is immediately kind of recognised. And then I think the thing that we tried to differentiate with, which I think you picked up on, was our kind of actually empowering patients to self-manage their care, and different people have different problems, don't they? Medication adherence, engagement with kind of actual services, just having more education around that, around their hypertension in itself. So we've been working, and you've started to put it in place, which is great. And for those who don't know what Florence is an intelligent messaging platform that has been working with hypertensive patients for almost 8 years. I mean, for example, in NHS Scotland, they've been doing remote monitoring using Florence and managing thousands and thousands of patients, and they've been able to identify new patients, support people to do their 7-day blood pressure, but they also support them in medication adherence and also medication titration. So really helping people get to the clinical outcome. And we use kind of just text messaging through algorithms, so that the patient feels like they're being communicated with. It feels like they've got structure in between the consultations with their clinical teams, and it helps them do the right behaviours to get to better health. So one of the parts of it, the first part, is onboarding, and you talked about efficiencies. What are you noticing that are in terms of like getting efficiencies in terms of administration and clinical team in the initial phase?
So if I just maybe start dipping on the protocols that we're using currently, then with that,
yeah,
that
sure,
helps put into context as well. So we've worked with a few practices and a PCN to kind of implement a couple of different protocols at the moment through Florence. So we're running a diagnostic protocol. Again, we've got huge numbers of patients coming through with the PCN DES IIF hypertension case finding. So again, we've developed a protocol that again asks patients for a one-off blood pressure, and then if it's high, it'll then obviously prompt them to take a 7-day one after that. If it's not, then we'll just be able to message them back and tell them that everything's fine. So again, that's a huge reduction in, because again, Florence can almost automatically follow that patient up, if that makes sense, because by them messaging back a correct blood pressure, it's telling them that everything is fine. and they don't have to, and somebody from within the administration team can just acknowledge the result and doesn't need to follow up that patient. Again, we're not also for practice, they're not, and a PCN, they're not having to follow up that patient. The patient's got the blood pressure monitor. They don't need to come back to practice and say, what do I do now? Florence automatically kicks them into the next step of the 7 days, at which then the information all comes back into a dashboard, and as a clinician or as an administration person, we can then directly see the blood pressure result that's come in, and we can look at the average, and we can look at the trends and everything again with it.
So before we go on to another protocol, so in terms of the diagnostic protocol, you set it up so you do an initial one, obviously that gathers those people who are already normal, and then Florence maintains the communication with them to reassure them and say, actually, you're absolutely fine. But then you as a clinician, interestingly, you can see the platform and you can see your patient cohort coming in, and you can see the communication happening between people. Are you using both? Is it just clinicians you're using on that platform, or are you using some administrators to do some of the streaming?
No. So again, in terms of obviously on boarding the patients and the patients, that will all be done through administration. But actually, no. At the end of the day, we have a protocol in place. They know when the blood pressure comes back in, they've got the thresholds to work to. If it's in range, they, like you say, so within that, obviously Florence will do the 1 day back automatically and notify the patient. They will then, the administration staff will then push that patient take them off Florence and say everything is fine and document that in the notes. Again, if somebody gets a 7 day, the administration staff will first obviously check the blood pressure. Again, they'll do the average. Again, if everything's fine, they can message the patient back and put the blood pressure result in the patient's notes. Actually, a clinician only really needs to intervene if the patients that remain in, as those are the ones that have got a raised blood pressure. Okay. And then we've and then we've then able to put them into dedicated hypertension clinics for the newly diagnosed. So
Okay, fantastic. And so what's some of the other protocols that you're currently using?
So we're using one actively, another one actively at the moment, and I'll tell you a little bit about one that we've got. It's nearly finished, and it's part of the work we're doing around the new diagnosis part.
Yes.
So the other one that we're using is the annual review protocol. So again, something that you've obviously used extensively. So we worked with 2 practices that've got large numbers of patients. So you're talking, 300 to 400 patients a month that need a hypertension review. So again, what we've been able to do with that protocol is kind of build it. We've worked with your team and we've worked with the GP practices to kind of build a protocol that fits and works with the current practice protocol for hypertension management, if that makes sense. So actually, it's been really and this has been one of the brilliant things with Flow, because you can actually, you can build it, you can personalize it, you can make it to what is needed for your patients, cohorts, and your practice. So actually, the annual review protocol again. What we've recognised with that is actually, to start with, actually, what we're doing, we're taking a cohort every month of the total practice population as an evaluation to start with. So we're putting about 100 patients on, as a bulk upload, and what happens is those patients will be contacted by Flow. Flow will check whether they've got a BP monitor at home. If they can't, can they borrow one or can they purchase one? And if not, actually, then what it does, it flags the patient through the dashboard back to us, so that then we can direct them to another way of getting their blood pressure. Again, it then obviously checks if they can use their BP monitor. It'll prompt them to go and get their bloods, and we've got links within Florence that tells them how to book a blood test, and then it moves them into the annual review. So again, we get those results back. We get Florence to check a BMI, we get Florence to check smoking status. So again, all that information that normally would need to be collected, through a letter going out to the patient or through an actual review with a clinician or a HCA, is actually being done through Florence. And what's really good as well is because we're getting the notifications back into the system as it happens. If we send a letter out to somebody, I don't know, we don't get anything back for 2 months. Actually, we don't know whether that patient's not engaged with us because they haven't got a BP monitor, or they're just not engaging. With Florence, we can in real time actually pick out the problem, why that patient isn't able to complete the protocol, and then the remainders we know are going to go through to completion. Again, same thing, our administration staff can have a look if the BP is in the range that we want it, or they've got, then we can message the patient back and confirm everything's fine. if they feel a clinician needs to see the patient, then they can leave them on the system, and then the clinicians can pick those ones that potentially need review, or if there's any other concerns from our administration team as well.
So it's fantastic, because I think in terms of doing the annual review, of course, it then can recycle round, and then the patient's automatically followed up in the background. And so once you've got people on board on the Florence protocols, then next year you've already got a really good efficiency running through. In terms of go on.
And I think as well, if we can, and I think our next steps, obviously we're learning from Florence all the time, we're building it, and we're gaining more confidence with it. So I think the other thing is we can actually maybe, like you say, within that protocol, develop that protocol. So actually 3 times through the year, it just prompts them for one-off BP. And again, if that BP is high, then it can prompt them to take an action. So if it's normal, it just prompts them automatically without us being involved, saying everything's fine, you're doing really well, reminding them, motivating them that they're actually doing the right things with their blood pressure. Again, if it's high, we can direct them, say, well, actually leave it a month, come and do it again, unless it's over, a much higher threshold than we want to be for safety purposes. And then actually, if it's high the second time, then it can prompt them back to us. And again, hopefully you're giving them that self-management, but also giving them the little prompts of what they need to actually, that reassurance. Am I right to contact the surgery? Yes, I am. I'm right to come back to you, because actually I've had 2 high blood pressures now. And then, as you say, then it builds, then we get the final, the annual 7 days at the end of that process as well the next year.
I'm super pleased that you've still really engaged with Flow, and you obviously went, how do we do our QOF process? But actually you've gone beyond QOF, and you're doing like the higher quality care, checking in with people because you have a continuous communication with them, and saying, well, actually, exactly, actually, is your blood pressure high at different times? And the other thing around really noticing who's not engaging. I mean, we've all learned, haven't we, from COVID, vaccinations, how do we reach people who are not engaging? There's so many different reasons for that, but at least you can start to gather some kind of information about why, and you can see the population that you need to identify. So that's great. You mentioned something called bulk upload, which of course you've worked with us to try and get as smooth as possible. Are you just so that people get a sense of, upload in bulk means, instead of just doing 1 by 1, it's actually you could do 100, 200, 300 if you want. How much time is it saving?
So if I was to do, so for instance, a manual, what I call like a manual upload would mean I'd have to take the patient's details from system 1, copy it across. So that would be things like obviously their name, their date of birth, their NHS number, a contact number. So that could take a couple of minutes to do each patient. Again, you've got to be very careful again when you're taking the information across that you're actually taking the correct information in as well. So with the bulk upload, so what the bulk upload allows you to do is upload a CSV file of your patients with all that information. So they're automatically on the system. And then once they're on the system, then the protocols or the algorithms will automatically once that patient's accepted, they're signed up to Flow, it'll start the algorithm event automatically. So what we've been working with you on is how we get the data out of system 1, and it's actually there's quite a straightforward way of actually getting the data out by using clinical. Again, I can't come in, obviously EMIS I'm not used to working with, but I work with system 1. So we've been working on how we pull that data out, and actually using recalls or read codes, we're able to actually pull our list of patients, pull it in the order that we need to. Really simple, and then as a CSV, like say 50, 100 patients, just literally put it into Florence, choose the algorithm you want for these patients to do, and upload. So again, I think now we've got it down to probably, but you can do it in less, probably I say 10 minutes. You could probably do it in 5 once you've got, you've got the cohort that you need to actually you want to manage as well. And I think
that's 5 or 10 minutes for that whole bulk of patients. Amazing.
So again, I think like anything, you've got to have your processes set in the practice. So you've got to recode, you've got to have your scheduled tasks then. But actually, if you've got patients scheduled to be contacted in March, you can just pull that list. And you can even exclude, obviously, part of the process, we exclude anyone that doesn't have a mobile contact or hasn't consented, for mobile consent or anything like that. So, and I think the other thing is, again, because the data's coming straight out of system 1, you're pulling it directly across, so there's less risk of making a manual error by entering somebody onto the system individually, if that makes sense as well. So
So that's great. So we've been able to try and find people who haven't been diagnosed. We've now got the people who are diagnosed. We've got them up on an annual review, and we can make sure the clinical team's focusing on the people who really need the attention. You've also got some titration protocol to try and get people to get to maximum tolerated treatment, or with some clinical governance. Can you just touch on that so that get a sense of it?
Yeah, so we've so as I mentioned, we recognise one of the problems is actually we look at our data and actually we're at our numbers are quite similar. Those diagnosed a year ago, within a year, are probably actually we got the same amount treated to target as we do for our general hypertension population. And I think what we've recognised is that actually we've got a huge variation in terms of how people treat hypertension in those early stages. So do you start low doses of ramipril? Do you titrate it gradually? And we've also found that we don't use a lot of combination therapy. And actually, if you look at the clinical trial data, I think something around 70 to 80% of patients normally need 2 medications for the management of hypertension. So what we've actually gone back to doing is looking at simplifying the process. So we are tending just to go in with our new protocol says just go in with 1 dose of a medication. So we've defined that as losartan, for instance, and losartan 50 and candesartan 8, or go for amlodipine 5 and lercanidipine 10. And because there isn't much additional benefit to increasing, what we've now said is actually at 4 weeks, if the BP is still raised, we do a second, we just add in the second agent. Again, obviously taking into account frailty and age and everything like that, not necessarily for those under 80. So actually Florence gives us that perfect opportunity now, because what we can do, what we've built into Florence is we built the titration protocol. So Florence will see the patient, we'll advise them, we'll give them 2 prescriptions, one for, depending on their other comorbidities and their age, etc. We'll give them a prescription either for an ARB or a CCB. We'll advise them which one to take, and then we'll sign them up to the Florence protocol. Florence protocol will remind them for the first week or 2 to take the medications that we've indicated, and it'll actually name the medication that they should be taking. It then gives them the option to carry on if they want reminders every morning. Again, and that also then allows us to see if any adverse effects are developing or somebody's not taking the medication. At 4 weeks, what actually does then is it prompts them to do a one-off blood pressure, and if that blood pressure is within range, then it'll prompt them to do 7 days. And again, at which point we can then review them if it's controlled or not. However, as we expect for most patients, if they're above the target that we're looking for, it will then automatically prompt them to take the second agent, and then therefore going through the same process again with a reminder at 4 weeks again to repeat their 7-day blood pressure. And again, we also have prompts in there around the bloods and everything as well in terms of that side of the management. So so it works really well for it. And again, it's reassurance to me. Again, I was working in a practice today, and we were actually looking at reasons why people aren't titrated to target on their blood pressure.
Yeah.
So I saw one patient who was started on lisinopril 2.5 milligrams in April and had never been followed up. So again, we know with Florence that that patient's on my dashboard. I'm going to see that patient. I'm going to see them on there and go, well, what's happening with them? And then the other thing was a patient who'd started on amlodipine, and I think they'd had it in their head that they haven't come back for 2 months. They've been started on amlodipine. Their next set of blood pressures were higher than their first. When we looked at it, they hadn't realised they needed to continue with the amlodipine. So they'd taken it for like two weeks or something, and then thought they were treated. So again, they've obviously now had to go back onto the medication. But again, that if they'd have had those reminders, then I think actually it would have prompted them you need to keep taking your medication, if that makes sense. And they would have been picked up for 4 weeks for their second blood pressure, for the first blood pressure anyway. So I hope that gives you a bit. Does that give you a bit?
No, that's absolutely fantastic. And we're really looking forward to seeing the results. We've got independent evaluation with the AHSN that will hopefully try and get a sense of where Florence really makes a difference, particularly in outcomes, but also in terms of practice efficiency. It's been fantastic, and look, thank you so much for your time, because I know you're super busy, and I just want to say thank you so much for being a brilliant customer to work with, having such great engagement from our partners and our customers enables us to make sure that our tools constantly kind of evolve to your in response to your needs. So I can't be sort of thankful enough for that.
No, and the same again. So it's been it's been really good to work with you guys. And again, it's been really receptive, because again, we have you put the protocols together. Not everything goes as you think it will the first time. But the team's been really quick. If we've noticed an issue with it, or we thought actually we could do this a better way, you know, Joe particularly probably gets annoyed because I probably contact her so much in terms of changing things. You know, well, not that often, you know, or just little tweaks. So yeah, no, so thanks. So again, so it's been really receptive, and we've got things changed really quickly when we've noticed it, so it's ready for the next cohort of patients that come through. So yeah, no, so thank you for
That's
for
great. Well,
as well.
Well, hopefully I'll see you, because we're also doing this in Sussex and obviously in Scotland and again Cambridge, and so we'll bring the community together and we'll try and do some learning together. So we can learn from what you're doing and vice versa. But maybe we'll get you back in 6 months' time, and we'll have some good hard data that we'll be able to share. So look, thanks very much for your time, and have a great rest of the day. I know you got to go. All right, all the best. Bye. Bye.
Excellent, thank you for that. That went into some great detail. We've now got time for a question and answers part of the webinar. So if you've got any questions, please type them into the chat and we'll go through them now. So to kick us off, the first question from Julie: how or will you be linking Florence into the NHS app going forward?
So in terms of the NHS app being integrated, obviously is integrated into your clinical record systems, you obviously will be able to see anything that happens in Florence that flows into that. We have had conversations around, well, actually, can you provide Florence through the NHS app? I don't think the app's quite at that place quite yet. But it is something that we've thought about, and if and when people are requesting it, it's something that we know we can now do.
Fantastic, thank you. During the video, there was a mention of protocols and changing them and adapting them, improving them as you go. Have you an example of that and what you did to improve a protocol?
So we've got a number of things that we've done. Obviously, particularly in hypertension, we cover many other long-term conditions, but particularly in hypertension, because of the length of time that we've been working with the NHS, we have some very established protocols. So first of all, you can diagnose people. Secondly, then if they need medicines, you can start medicines and titrate people. Then of course you need to monitor people in terms of their blood pressure, and then you can do sort of your annual review. So that's all well and good, but more importantly, we need to think about who are we engaging as well. So what we can do is we can particularly change the messaging. So we can work with patient groups that are maybe a bit more difficult to contact or engage, and we can change the way in which Florence talks to people so that we get more engagement. We can change the language if there's a particular language issue, so that we can really pay attention to maybe some of those people that don't normally engage with us. And then other things, like we have a really good feedback system with our customers. So once we've launched a protocol, we have a really good process with a customer to ensure like what's working, what's not working, and we're able to adapt things. And then as you become more au fait with Florence, for example, in Nottingham ICB, they have like a Florence person who can use the platform and change the protocols and design them themselves. So you can become more of a mature user over time.
Fantastic, thank you. This was touched on in the video. In terms of those people who are not engaging and identifying them, how does the software work around that? Could you just take me through that, please?
Yeah, sure. So if you take a population that you may want to try and get onto Florence, obviously you can identify that first, and we work with the customer to understand, what's the problem we want to find. So is it we want to diagnose high blood pressure? Maybe there's blood pressure readings in your notes that you've got slightly out of range, but the patient isn't necessarily recoded as having high blood pressure. So we can take that cohort, we onboard them onto the system, and then your clinical team will be able to see those people on the system, and our platform enables you to see who's engaging with the technology and who isn't. And so it's obviously about 60% of people who engage just get on and use the protocols, and you don't get much work going into the practice at all. But then you can really focus on those people who either their ranges are going out of range or they've not engaged. And it's those practices, and particularly, it's becoming more and more important, isn't it? Around identifying these particular groups, and you can think of new ways of doing it, and that might be a different way of introducing Florence to people, using more verbal human contact with either the HCA or with a clinician, or maybe someone within the community can start talking to them, say let's try and get you on board. And then the other things I've already mentioned to you, we can just change and adapt the actual messaging in partnership with patients.
Fantastic, thank you. Does the software, can it change to adapt to other languages when English is not the patient's first language?
So we can use plenty of languages, but we have to build the algorithms in that language. So we'll work with the customer where they particularly want that, and we ensure that we get the communication in that way, and make sure we get the local translation done. So we can communicate in really in any language, but it's something that we make specific to a particular population group.
Okay, fantastic. How does the end user enter data into Florence? Is it a native app or website?
So when you say the end user, we're talking about a patient who's using it. So it's SMS text messaging because it's the most inclusive form of communication. So there's been plenty of use of where people use apps, and there's reasonable evidence to suggest that people get bored of them or stop using them quite at some point. Whereas text messaging, most people are used to text messaging, and a high use of people who have a mobile phone that have that functionality. So you don't need a smartphone. So you just communicate with Flow in a way, and if you answer particular questions in particular ways, you get asked different questions, and we start to learn a little bit about an individual and what might make a difference to them.
Fantastic. In the video, it was mentioned about you going through an evaluation on outcomes, and that might be 6 months' time when it's published. Is there anything available, any early data available now that you can share, or maybe the benefits?
Yeah, so look, as I said, we've been running for over 8 years in NHS Scotland. They have evaluation data, so it's been published in different journals. So if you use Florence and you don't use Florence, you actually get about 5 mm of mercury reduction on top of what you normally would if you're working with your patient group. And of course, a 10 mm of mercury reduction results in a 20% reduction in heart attacks and strokes in the future. So there's a clear evidence-based kind of publication to show that. We also know that it saves significant money both in administrative time and also in appointment time. And in NHS Scotland, been releasing some data. It's saved, because we've worked for so many years, saved millions of appointments. And I mean in that level, because they've used over thousands and thousands of patients. So it's a very robust, trusted piece of technology, which is quite a differentiator in the current market. There's lots of new people in the market, but this is something we've been doing for quite a very long time.
Fantastic, thank you. Well, we don't have any more questions, so if anybody has any questions outside this meeting, feel free to email myself. My email's john@htn.co.uk, and I can help connect you with the right people. Like I mentioned at the start, the session has been recorded and will be available on HTN soon, whether you want to read or watch it back, and you can share it with your colleagues if you want to. So I'll look to close the session here. Thank you, Jonathan, for joining us, and pass on our thanks to Matthew as well for taking the time to talk about your project in Bedfordshire. And we look to welcome you back as well, like you said in the video, in 6 months' time when you've got the evaluation. That would be great.
Yep, that's great.
And thanks to everyone for joining. So I'll look to close the session here. Thank you, everybody.
Thank you very much.
Thanks a lot. Cheers. Bye.